And welcome everybody to today's Pathology Grand Rounds lecture, sponsored by the Jean Shanks Foundation and the Pathological Society. Can I remind audience members, if you have questions to ask at the end of the lecture, please can you type your questions into the Q&A box, which is available through a button at the bottom of your screens, and I will read out the questions at the end of the lecture. It gives me great pleasure to introduce today's speaker, who is Professor Christian Ottensmeier. Christian is a medical oncologist who trained in Münster, Germany, followed by a fellowship at the Dana Farber Cancer Institute in Boston. He completed his PhD in molecular immunology in Southampton. He was appointed to a chair in experimental cancer medicine there in 2007, and in 2019 to an Associate Professorship at the La Jolla Institute for Immunology in California. He joined the University of Liverpool, the Liverpool Head and Neck Centre and the Clatterbridge Cancer Center as a Professor of Immuno-Oncology in August 2020. And since January 2022, Christian has served as the Director of Clinical Research at the Clatterbridge Cancer Center. He leads an early phase portfolio of trials to deliver more effective immunotherapy with a focus on both head and neck cancer and lung cancer. And his laboratory studies how best to induce tumour antigen-specific immunity through vaccination and how to overcome immune suppressive features of the tumour microenvironment. And it's on that subject he will lecture to us today with his lecture entitled Activating Tumour Reactive T Cells for Cancer Immunotherapy, There May Be a Problem. Thank you, and over to you, Christian.
Thank you so much for your very courteous and kind introduction. Are my slides up on the screen? Can you see them?
Not as yet, no.
Okay, let me see if I can do the share again. Working now?
Yes, it's working now. It's in presenter view. If you could put it into full view, please.
Okay.
We're still in presenter view. If you could change that to the full view, please.
Okay. Believes it's in the right view. Let me swap my.
Sorry, go on. Do what you're going to do.
Just unplug one screen. Any better now?
You'll need to do the screen share again.
There you go.
Yep, that's better. That's perfect. Thank you.
Good. It's always frustrating when it works in the practice and doesn't work in real life. So hopefully we'll have no more technical hiccups. Thank you so much, Mark, for your very kind introduction. So the aim of the presentation today is to take you through a sort of overview of how I think about T cell biology and how I think about the problem of pointing T cells at tumors. So we know that for cancer immunotherapy, effector T cells are at the heart of the clinical control that we see when we make patients better with modern immunotherapy. And I'm going to try and look at why that might not work, and then hopefully offer you some thoughts about what we might be able to do about this. So I've been privileged to live in a period when cancer immunotherapy has grown up from being an exercise for the initiated and the slightly crazy to becoming a mainstay treatment in many solid tumors. And we now treat using checkpoint inhibitors, particularly anti-PD-1 antibodies, in a very large percentage of solid tumors. And in some tumor types, such as lung cancer or melanoma, we treat throughout the spectrum of disease, from the neoadjuvant to the advanced disease spectrum. With single agent compounds, we get really quite dramatic effects in about a quarter of the patients. And we're really learning that if we push the right buttons, using immunotherapy, then we can achieve long-term disease control, and I think cautiously, in some patients, can even cure cancer. And that is really quite remarkable, because when I started in oncology all those years ago, we were really writing home about a 6 or 7 week median improvement in overall survival. And most patients, or in fact, the vast majority of patients died. So there's been a really big landmark change. And in some solid tumors, in particular melanoma and lung cancer, with combinations of drugs, either with chemotherapy or with checkpoint inhibitor combinations, we achieve a response rate of about 50%. And this all happened after 2011, when the first big paper in melanoma demonstrated that immunotherapy could help a small group of patients. But it feels now as though we're stuck. Over the last 5 or 6 years, drug after drug has been tested. New checkpoint inhibitor antibodies have been tested, and relatively little extra benefit has been achieved. So the problem then becomes, why might that be? And it's emerging as we look in the tumor microenvironment. And that's sort of my secret pathology hankering that speaks here, is that we can actually see the T cells in the tumor microenvironment, and we can see that they're sometimes separated from the tumor, sometimes interspersed with the tumor cells, and sometimes they're just plain absent. So then if we think about the problem of cancer immunotherapy failure, and think about it from the perspective of a T cell, then they could either be turned off, or they could be actively inhibited by other T cells. There could not be enough of the T cells, or they might not be able to get to the tumor cells. And we now know that, of course, this is a highly prejudiced view, because in the tumor microenvironment, there are other cells, such as myeloid cells, and of course, the fibroblasts, and I'll refer to Professor Gareth Thomas's work towards the end of the lecture in this space, that contribute to failure, but particularly for the myeloid compartment, we're still not in a place yet to really drive managing that. So the question then that I would like to think with you about in this presentation today is whether it is possible to make successful decisions about treatment before you actually give the treatment. In other words, predict per patient what you might want to do and what kind of drugs to give to the patient. And this sort of takes us into the era of stratified immuno-oncology. And we now know that at the very personalized end of this, we're also beginning to make treatments, particularly cancer vaccines, specifically for an individual patient. So I guess in that space, then stratified meets personalized. Our own work has made a contribution to this space, and we were among the first group that really identified that a group of T cells that live in the tissue, that do not or recirculate only very little, are contributing critically to clinical outcome. And because they are resident and they're memory cells and they live in the tissue, they have acquired the Kachi shorthand tissue resident memory cells. We know that in a vast majority of solid tumors, and even in hematological malignancies or lymphomas at least, these tissue-resident memory cells are key correlates of protection. And if you quantify, and that's what I've done in the graph on the left-hand side, the number of T cells in this case, a group of lung cancer patients, this is an N of roughly 600. If you quantify the tumors that have few or a large number of T cells, then you can substratify not just whether they have CD8 T cells present or absent, but whether the T cells make a particular molecule. It's an adhesion molecule, an integrin called CD103, binds to E-caterin in the tumor microenvironment. And this molecule is a sort of abstract shorthand for a whole transcriptomic program that keeps T cells in the tumor microenvironment. And it's really easy to stain for. So this is in the immunochemistry stain that Gareth Thomas did for us, which measures CD103, PD1, and then on the left CD8 in a tumor that's rich in T cells, and at the bottom in a tumor that is not so rich in T cells. So what we've learned is that these cells are highly effective killers. They expand in the cancer tissue. They express unique and actionable targets, and they are present in multiple cancers. They can be reproduced in mouse models. We now know that they underpin protection against tumor challenge. They're activated by anti-PD-1 antibody, and they can also be induced by vaccination. So our group really focused on T-cell biology in solid tumors, head, neck, and lung cancer, mainly from the perspective of, if you categorize tumors now into those tumors that have lots of these good cells and lots of these bads, or don't have many of these good cells, what happens to other cells in the tumor microenvironment? And so I think the first prediction is that tumors with enough tissue-resident memory cells will just need an anti-PD-1 antibody to be treated successfully. So the selection marker is relatively straightforward. You could look at CD103 in the CD8 positive T cells, and anti-PD-1 antibodies will wake these T cells up, and they will then wander off and kill the tumor cells and hopefully control the disease. And we know that the PD-1 antibodies treat successfully, as I said, about 25% or so of patients with lung cancer if you give them single agent. And if we categorize the patients with lung cancer according to how many of these tissue-resident memory cells they have, it matches reasonably nicely, although what is still missing and would be needed for clinical decision-making is where the threshold should be for making a decision for anti-PD-1 alone. So this is a larger data set, not our own data set, of a group of patients with head and neck cancer. It's almost 1,500 patients. Each column is a patient. Each row is a set of genes, so gene signatures such as angiogenesis or cytokines and so on. And they've been categorized using mRNA sequencing of the whole tumor. So essentially, you mush up the tumor, you sequence all the mRNA in the tumor, and then you get a readout for genes that are expressed in this individual tissue. And if you now begin categorizing the tumors, then sort of four big pots emerge. So I'll take you from the right. These are the tumors that have not very many immune cells. They I think, are the equivalent of what we call immune deserted. Then there's a large category which doesn't have a great deal going on immunologically, but which are dominated by cancer-associated fibroblasts. So these would be the fibrotic tumors, and the sort of graph is at the bottom. Then there are the tumors that I've just referred to. These are the ones that are rich in T cells, that don't have much of fibrotic activity going on, so few CAFs. And I think they're the ones that benefit from anti-PD-1 antibodies. And they're also the ones that are rich in CD103 positive TRMs. And then there is a mixed bag, which I think will ultimately work out to be these immune-excluded tumors, where the cancer-associated fibroblasts block T cells from entering the tumor. So this kind of data set begins to categorize, in this case, head and neck squamous cell carcinomas at diagnosis, into perhaps groups where you might be able to consider whether there is a unifying strategy in biology that you could perhaps address. And we could perhaps, for example, propose that here you would use a vaccine, here you might want to use a CAF modulator. So the difficulty, of course, in all of this is that if you use transcriptomic data sets, you get a range in a cohort, but it doesn't give you absolute data. So abstracting this into more user-friendly immunohistochemical tools would be, I think, a really key piece. So what we've also learned is that in this group of immune-rich, non-fibrotic tumors, there's not just the effector cell population, but there are also other T-cell populations, some of which are also very highly expressing the PD-1 molecule. And if you think about PD-1 as a biomarker for how well the T-cell is trying to do its job, in other words, recognizes antigen through its T-cell receptor, then the quantity on a per cell basis of PD-1 expression marks the quality of the T-cell response. Or in other words, if you've got T-cells that makes lots of PD-1, they're trying really hard to mediate the effector function. And so normally we think that an anti-PD-1 antibody will release inhibited effectors and then activate cytotoxicity. But there is a second population, the tumor microenvironment, that are regulatory, that are of a regulatory phenotype, that also make a lot of PD-1, and these cells are called T follicular regulatory cells. These are well recognized in infection because they are key players in the germinal center of making an antibody response. And our contribution has been to define for the first time that these inhibitory cells also play a major role in cancer. So what you wind up with, and I'll show you a little bit of data in a minute, is a sort of yin and yang of T-cell attack, all marked by high degrees of PD-1 expression. So the effector cells that we're desiring and the inhibitory cells that drive an immunosuppressive microenvironment that are also released by anti-PD-1. And I think depleting these, for example, with an anti-CTLA-4 antibody would be one way of going around making these cells disappear. We know that they are primarily located in germinal centers, hence the name, follicular regulatory cells. Their molecular transcription factor that characterizes them is BCL6. And these cells derive from regulatory progenitor cells. They're highly suppressive. And in the germinal center, their main function is to help mature a high affinity T cell response. So they're suppressive of B cells, a high affinity T cell response. They suppress B cells and suppress T follicular helper cells. So the net result is that if these cells are active, only the very best and the most activated B and TFH cells can do their job successfully. So it came as a bit of a surprise when we examined our own data set. This was the lung cancer data set from which we started, and found that in the single cell analysis of lung cancer T cells, there was a really significant proportion of these regulatory cells that were clearly participating by virtue of having all the activation markers that an effector T cells has, but that expressed FOXP3, that was CD4 positive, and that made a lot of BCL6, or CXCR5 is the other chemokine that goes with these cells. And so we started off by looking in a whole range of single-cell data sets that have been made available in the literature at the time, and turned out that our observation was by no means unique. We found them in lung cancer, and two other groups had also found cells of this flavor, although hadn't reported them, but they were present in the single-cell data set, but also in melanoma, in head and neck cancer, breast cancer, colorectal cancer, liver cancer. And so I think this is probably a generic feature of an inhibitory cell population that's trained possibly in the tertiary lymphatic structures in the tumor microenvironment that contributes to the immunobiology in many solid tumors. And it came at a time when we were talking with this gentleman, this is Bart van Hazenbroek, who then was in St. Bartholomew's Hospital, who had just reported in Nature that an inhibitor of PI3 kinase delta, which is a molecule that sits downstream of the T cell receptor, was able to inhibit regulatory cells relatively selectively and made T cell responses against pancreatic cancer, in this case, clinically or preclinically successful. So we undertook a clinical trial in collaboration with Cancer Research UK, or funded by Cancer Research UK, and Bart was the key driver of getting us over the table. And the key academic collaborators in this work are a gentleman called Vijay Nanpandurangan, who is the PI here in the La Jolla Institute and whose lab I'm closely affiliated with, Simon Eschweiler, a really gifted postdoc, and Mitch Cronenberg, who's was then the head of the institute. And we were able to demonstrate that in head and neck cancer, when we gave these kind of compounds before surgery, we're actually able to remove regulatory T cells from the tumor microenvironment, not by killing them, but making them move into the blood. And that released an anti-tumor CD8 T cell response. And so that has taken us into a wider analysis of single cells in head and neck squamous cell carcinoma. And that was one of the key reasons I moved to Liverpool to work with the Head and Neck Centre team, the surgical team here in Liverpool. And what we are now doing is probing systematically what the distribution of T cells, or maybe more widely immune cells, in the head and neck tumor microenvironment. And it's really intriguing that there is a really quite significant population of regulatory T cells. So this is a UMAP, it's called. Each dot is a single cell. These are data from about 60 patients, and I've labeled them according to the most dominant T cell populations, in this case, in the CD4 gate. And when we also look at T cells that are in the adjacent mucosal tissue, you can see that the regulatory cells, in this case, containing a significant TFR population, mainly come from the tumors, so in green, and there is only a small percentage in adjacent tissue. So again, verifying that this biology is real. And when you look at these cells functionally, then you can pick out, for example, compared to regulatory T cells on the left, how the T follicular regulatory T cells behave at a single cell level. And these plots, they're called violin plots, identify on a per gene basis, so abstracted from this data set, what the particular features are of the cells that we're interested in. So, for example, this plot here is CD137 or 4-1BB, suggests that these cells are highly activated. So they make more 4-1BB, but on a per cell basis, they also make more. And more cells make 4-1BB. They make inhibitory receptors, so for example, the GIT receptor, and they make PD-1. So they are clearly participating in the functional biology of the tumor microenvironment, and we think that they're likely seeing tumor antigens in the tumor microenvironment that are driving this biology. And here's a data set with flow analysis, which essentially confirms the same thing. So on a per cell basis, these make the most CTLA-4, as well as the highest percentage of cells that make CTLA-4. They're the highest PD-1 expressors and the most cells that contribute to PD-1 positive population. So you can imagine then if you give an antibody and unblock these cells, the clinical outcome will be decided by what the balance is between the effector cells that you unblock. If you have lots of effector cells, you make things better. But if you have lots of these inhibitory cells, you'll make matters worse. And that is clinically coherent with a small percentage of about 10 or so % of lung cancer patients where you give an anti-PD-1 antibody and things just explode, this clinical hyperprogression that the clinicians recognize. So then to summarize the section on these cells, these follicular regulatory cells are present in the tumor microenvironment. They have a really clear molecular shorthand, so they make FOXP3, they're CD4 positive, they express BCL6, they also make the chemokine receptor CXCR5, and they express the GIT receptor. They are trained, we think, in lymphoid structures. They likely focus on self or altered self, so seeing tumor antigen, and they're activated by anti-PD-1 antibodies. And if you now ask then what happens in a mouse model, this is a B16 model of melanoma, if you first deplete these regulatory cells and then give an anti-PD-1 antibody, you get much better therapeutic effect if you take the Tregs out first. And in our clinical experience, and this has all the limitations of a retrospective analysis, it demonstrates that if you give anti-CTLA-4 first in patients with melanoma and then rescue the patients with an anti-PD-1 antibody, you get the expected 50% or so rescue. But if you do it the other way around, give anti-PD-1 first and then at progression give an anti-CTLA-4 antibody, then that doesn't seem to work clinically. So suggesting, therefore, that there is a genuine problem with this kind of biology that is determined by the balance between regulatory and effective cells. So I think that these cells also curtail, for example, anti-PD-1 treatment by soaking up available anti-PD-1 antibody in the tumor microenvironment. I've already discussed how they divert the anti-PD-1 effect and alter the cellular composition by shifting the T-cell infiltrate towards a regulatory setting. And I think there are a number of tools that are becoming available or are already available. So anti-CTLA-4 antibodies, anti-GIT receptor, anti-IL-8 receptor antibodies. But we know that these are not selective for the T cells in the tumor microenvironment because, of course, regulatory cells play a major role in our healthy structures, such as the barrier organs, skin or bowel. And so we know that anti-CTLA-4 antibodies cause lots of immune-related toxicity because we are depleting inhibitory cells. And we are therefore very keen on exploring further whether these PI3 kinase delta inhibitors, which have a really short half-life, might be able to overcome this problem because they might be more controllable in terms of the toxicity. So prediction number 2 then would be that if you have an inhibitory cell population, that you might be able to pick those out, and stratum 2 in our tumor categorization would be the TFR-rich tumors. But of course, I'd already alluded to the fact that in many patients there simply are not enough immune cells, and immunotherapy that relies on waking up cells that have been inhibited therefore cannot work because there's nothing to wake up and reactivate. And the immune-deserted tumors clearly need a different strategy. And the proposed solution for this would be to train new immune cells in the patient, and the proposal how to do this is to use vaccination. So conceptually, then the process would be that you read out on a per tumor, or indeed, as you may know, on a per patient basis, what makes the cancer cell different to healthy cells, turn that into that genomic information into a vaccine, and vaccinate the patient, and then hope for the best and see whether it actually improves outcomes. And the sort of differences between tumor cells and healthy cells can be categorized in different classes of tumor antigens. And that is important because the molecules that are shared with healthy cells have a built-in regulatory mechanism which is active in the thymus, which tries to remove T cells that are good at seeing self-antigen, so in a process called central tolerance. But as you move through categories of antigens, antigens that are found only on the tumor cells, for example, after viral infection, HPV or EBV are really good examples in many solid tumors. Finally, to these antigens that are ultimately the process of the malignant the product of the malignant population, you would predict that you have decreasing levels of problems with self-tolerance, and therefore hopefully that will translate into better T cells if you vaccinate against these targets. And so this field, after really many years of not being very appealing at all, suddenly exploded at the end of last year when Moderna released their first randomized trial in resected high-risk melanoma, where they'd given patient anti-PD-1 antibody, here graphed in the black line, and randomized patients to also receive a truly personalized, in this case, mRNA vaccine. And it's quite a stunning effort to have achieved this through the COVID pandemic. And the whole area of cancer vaccinology is now galvanized by this observation that there is a differential effect of vaccines delivered in this way, even though one has to be a little bit worried that at the 160-week mark, so after 3 years, the curves seem to come together, so there seems to be a transient clinical effect in terms of relapse-free survival. Clearly, there are other targets that are unique to the tumor cells, and some of the molecules fall into the category of shared antigens that are in the cancer testis antigen family, so cancer because they're on cancer, and healthy structures on the testes. And a number of these antigens are targets that we're developing ourselves. So 2 antigens, for example, MAGE-D4B, which we're trying to take into the clinic because it too falls into this category of selected antigens that do not seem to be susceptible to central tolerance. So it will be very interesting to see whether this kind of immunogen can be successfully deployed for clinical intervention. And we certainly know it's immunogenic because patients make antibodies and T cells against it. So I'm quite hopeful that if we take this into a clinical trial, that this may actually work. In a preclinical model, and in this case using a DNA vaccine, you can see that you get tumor control, and if you combine it with an anti-PD-1 antibody, the tumor control is best, suggesting that there is a pathway, just like the Moderna team have done, of combining these vaccines with an anti-PD-1 antibody to protect the cells from being turned off in the tumor microenvironment. And we're using a new way of making DNA vaccines, which is a biochemical method, which is super quick. And we hope to be able to test this kind of approach in lung cancer in the early part of next year to get together here in Liverpool. But I wanted to just spend a few more minutes on this concept of making a new vaccine for each patient, because when I sort of came out of my PhD, this would have felt like science fiction. And really, the revolution in genomic toolkits has made things possible that were unimaginable 15 years ago. So you can take a sample from the tumor and read out the whole exome and work out which of the exome actually makes into mRNA as a sort of biomarker for will likely also turn into protein. You can then subtract the genomic information from the germline to figure out what is genuinely different in the tumor cells. And this technology is now really well established, and you can identify those genomic abnormalities or mutations that are potentially going to turn into protein that is processed and then presented in MHC class 1 and class 2 molecules as peptides. And that's the sort of terminology that we call, or that's a process that we call neoantigens. The bioinformatic pipelines are still not 100% robust, and everybody does it slightly differently. But clearly, the Moderna data suggests that this can work, and indeed, a number of other groups are in this space also. And if you make near-epitope prediction, and then you can, of course, test whether they're immunogenic, you can make a string of beads of these peptides and use that in a vaccine. In our series, we've used a viral vector, a modified Vaccinia ankara. We've made a vaccine for every patient and then randomized the patients to have the vaccine early or at relapse. And it looks as though in a small phase 1 randomized study, we haven't seen any relapses in the vaccinated patients, but a number of relapses in the patients who have not been vaccinated. So suggesting that this may actually lead to some useful effect. Single agent in this case, without anti-PD-1. And when the same kind of concept was used in a cohort in the US in a phase 1 study in ovarian cancer, here is the CA125 on this patient's timeline, and patient was vaccinated at this point and then remained disease-free for roughly 9 months, but then passed away from COVID. So suggests that even detectable disease might be amenable to this kind of thing. So then the tumors with few T cells who do not benefit from anti-PD-1 antibodies need training of new T cells. The selection markers would be for the TIL low cancers, and we'll see whether this kind of categorization actually works. And certainly there is a lot of work going on internationally, and many groups are working in this space now. And I don't really have very much of our own data to contribute here. So these are data from Gareth's lab. And he's been doing a fantastic job of taking these kind of concepts in the clinic. Here, the cancer-associated fibroblasts isolating the tumor cell nests from T-cell attack. This is a typical immune-excluded tumor. And then there are now, and we know that these cuffs link with poor outcome in a whole variety of solid tumors. And if it was possible to remove these cuffs, then that would be, I think, a really good category to add to our armamentarium. And small molecule inhibitors, such as, for example, NOX4 inhibitors, are entering the clinic or have entered the clinic. And so we're eagerly awaiting the data from the early phase 2 study that has this almost completed now. So then this leaves us with a biological model where we have different categories of tumors, those that are TRM-rich, that are follicular regulatory cell-rich, that are cuff-rich, that are TRM on T-cell low. I think that will still leave about a 30 to 40% residual piece of the cake that is driven, I think, mainly by myeloid cells. So we'll have to learn what to do with those. But at least we're beginning now to be in a position to make decisions about what we would do. And that leaves me with a summary. A successful immune system trains memory cells. A successful cancer also trains regulatory cells, which offers another layer of protection against immune attack. PD-1 activates both the effector and the inhibitor cells. Too few cells means that immune recognition is limited, and maybe this can overcome by vaccination. Removing the fibroblasts or modulating them will, I think, be a key contribution to systematic building of intellectually designed cancer immunotherapy trials. And I think we have a whole raft of antigens that we might be targeting against. And I think we need to do this really carefully with standardized monitoring. And I think that this is feeding us into a time when we're really beginning to use the biology of the tumor to make decisions about what we should do for our patients. It's a super exciting time to see this all happen. And with that, I would like to thank you for your attention, take any questions, and thank all the many people who have made this work possible that I was allowed to speak about today.
Okay, thank you very much indeed, Christian. That was a really interesting lecture, which I thoroughly enjoyed. I'd like to kick off with a question, if I may. When you were talking about the head and neck cancer trials towards the end there, and you were talking about using the differences to generate a patient-specific vaccine, were any of those cancers defective for mismatch repair with very high mutation rates?
So no, they are actually, none of them have mismatch repair deficits, and most of them were still low, and a fair number of them were also CAF-rich. So as you would have expected, they are all HPV negative tumors. As you would have expected, 85% or so of these tumors are low in T cells, and that's a sort of tour de force of immunotherapy trying to achieve something. So that's why it's so super exciting that there seems to be an early effect.
Okay, thank you. So if I could remind the audience, please, if you could type your questions into the Q&A box at the bottom of your screen, I will read them out for Christian to answer. So I'd like to start off with a couple of questions from Sarah Coupland, if I may. Sarah's first question is, with the cancer vaccines, should we be concentrating on the primary or metastatic tumours to develop these?
Sarah, lovely. So in the setting that I've talked about here for the TG4050 study, we only have the primary. So you can't really, you're dealing with the primary, you're using the primary for the information, but you're trying to prevent metastatic disease. And the delivery or the development of micrometastatic disease that we can't sample into a clinically relevant disease. So I think that is likely going to be the Achilles heel of the personalized cancer vaccines, because you're by necessity having to make predictions about what happens in advanced disease at a time when you can't assess it. And we know that the genomic profiles change, not just within the primary tumor in geographical areas within that, but also between metastases, and different metastases have different patterns. And the group from Charlie Swan has done a marvelous job at sort of tracking that. So I think that for this kind of biology, we will need to also consider whether we need to target shared antigens that are maintained throughout the disease course. And that's one of the reasons we are so interested in this MAGE-D4B as a target, because it is maintained from dysplasia to advanced disease. So really absolutely spot on the question. Ideally, we'd sample everything. Clearly, you can't do that. It costs $100,000 to make a new personalized vaccine. You can't make that multiple times for an individual patient. And I suspect the coming together of the curves in the Moderna trial suggests that actually you lose control over time because you haven't picked all the key antigens that are immunogenic and make the patient's tumor different.
Okay, thank you. So Sarah's second question is, how often do the patients require vaccination in the trials, i.e. how long is the immune stimulatory effect?
Again, I think it will depend on the platform used. In the TG4050 trial, we gave 6 doses at weekly intervals, and then for up to 2 years at 3 weekly intervals. We don't know whether that is sufficient, necessary. We know that it leads to very nice, durable CD4 and CD8 T cell responses that extended beyond the time period of vaccination. For the mRNA vaccines, T cell induction seems to be less robust than for viral vectors, and also seems to be less durable. So we'll have to see what the outcome will be and how often you need to revaccinate. The answer is not known at the moment.
Okay, thank you. So a question from Bharat Jasani. Bharat asks, are we in a position to recommend which block one should select for PD-L1 immunohistochemical staining?
So, no, I don't think we really do, because I think there is geographical variability for T-cell infiltrate, as well as the tumor biology may vary according to where you are. So we therefore assume that the average expression tells us sufficient information, gives us sufficient information to make a decision. But of course, we know that that is incorrect, and we often get it wrong, and those patients then don't benefit. And of course, PD-Ligand-1 expression is driven not just by interferon, but may also be driven by a whole load of genomic and epigenomic phenomena. So unfortunately, I still think if it was possible, we should look at all blocks and make a better assessment. But of course, in clinical practice, that's challenging.
Yeah, of course. Okay, so moving on to another question, this time from Graham Murray. Many thanks for an excellent talk. How straightforward will it be to maintain a favourable effector to inhibitory T cell profile which presumably is a dynamic process, is there a risk of resistance emerging?
Yes, again, really perceptive question. So we think that anti-PD-1 antibodies are particularly good at activating the effector cells. So in other words, the cells that are no longer self-replenishing, and so the molecular marker for those stem-like cells is the transcription factor TCF1 or TCF7 at the protein level. Now, anti-PD-1 will not reinvigorate those very effectively, although, again, the data are slightly controversial in the literature, suggesting that ideally you would want a molecule or an antibody or a target, indeed, that would also activate the stem-like cells. So then you would sort of feed forward into making more of the right kind of cells. I think that some of the secondary failure also is a reflection of the wrong shift happening. So, you know, as the tumor grows, you train more and more of these T follicular regulatory cells. And therefore, if you unleash those, then gradually you would shift the activity towards those cells, particularly if the cells that are doing the controlling are becoming exhausted and not being replenished. So I think this biology hasn't been formally assessed yet, but that's what sort of my reading of the tea leaves is. And I think we will therefore find different reasons for secondary failure of PD-1 checkpoint inhibitor treatment, which includes these biological mechanisms.
Yes, thank you. So another question from Barrett, who asks, is the presence of tertiary lymphoid structures good or bad sign for PD-1, PD-L1 directed immunotherapy?
I think we know that TLSs are the locally trained immune response that is the result of an adaptive immune response to the tumor. So B cells, T cells congregate together and form a germinal center. So therefore, conceptually, you would have to think that the germinal centers are the place where tumor antigen is used to train an adaptive immune response. And indeed, as far as I know, there isn't an example where TLSs are an adverse feature. So if we stay within the limits of the presentation today, though, you must fear that if you have a TLS that churns out T follicular regulatory cells, then you might actually activate the wrong cells along the lines that I've argued. And what is yet unclear to me is what the interplay between the TLSs are and the T cells that are in the stroma of the tumor, because the TLS proper doesn't, the Tregs or TFRs in that don't block the T cells that kill the tumor. That happens next to the tumor cells. So where the cytotoxicity of the TFRs kills the affected T cells. So that interplay, I think, will be evaluated when we get better handle on the spatial transcriptomics and can follow T cell receptors from within one structure into other areas of the tissue, because while the single cell data analysis allows you to track T cell receptors and clonal relationship, it doesn't tell you where the cells come from because you disaggregate the tissue. So that spatial analysis is lost. So I think your question will find its answer when we are able to apply spatial transcriptomics, including T cell receptor level at single cell level on FFPE tissues, which I think will allow you to probe this. I don't have an answer at the moment.
Okay, thank you. So moving on to a question from Adrienne Flanagan. Adrienne asks, are there any insights into the molecules that restrain the T cell infiltrate?
Molecules. Yes, I think there are multiple pathways. So we've talked about the CAFs already, and I've spoken about them because I'm so excited by the work that Gareth is doing in this field. And so these are cells rather than molecules, I guess. So there's SMAD signaling. TGF-beta plays a major role. But TGF-beta is one of these odd cytokines that are also critical for TRM biology. So no TGF-beta, you don't get the inhibitory effects, but you also don't get very good tissue-resident memory T cells. clearly other molecules that have to do with the extracellular matrix and how cells go through that. So some of these integrants, alpha V beta 6, alpha V beta 8, come to mind. And then the myeloid cells will play a major role. So molecules that have to do with suppressive function of immunosuppressive macrophages and myeloid cells will, I think, play a role here also. We're just beginning to probe this space, so I don't really have an expert opinion to offer here.
Okay, thank you. So Adrienne asks a second question, although I suspect you may have already partially answered it, but I'll read out her second question. Do you predict that there will be multiple mechanisms by which the fibroblastic cells restraining the T cell infiltrate?
I'm sure that's the case. The best person would be to ask is Gareth. I'm just a poor lowly oncologist, and I don't know enough about fibroblast biology, but certainly from the data sets, the single cell data sets that have been published, it is very clear that CAFs come in multiple flavors. And I suspect that they all have varying functions depending on also where they come from and what the originating cell is. So a complex area that I think is beyond my own laboratory science, but I think it's very clear that heterogeneity exists for all the cells in the tumor micro, or the categories in the tumor microenvironment, including the CAFs. Sorry, that's a waffly answer of I don't know.
Okay, well, that's fair enough. So moving on to a question from Alistair Easton, who asks, are the T follicular regulatory cells present in draining lymph nodes, as tertiary lymphoid structures aren't present in all tumours? Are there any studies quantifying them here?
It's a really interesting question. So yes, any lymphatic structure will contain TFRs, not least because they're sort of developed from Tregs, and there may be an interplay between T follicular helper cells and TFRs. So absolutely, and I think the tumors that don't have TLSs still can have TFRs. So it is not only the TLSs that provide the TFRs in the tumor microenvironment. I don't know how the quantity of TLSs links to the number of TFRs. So that's a piece that we would like to look at. You need full phase sections and the right antibodies in the multiplex immunohistochemistry. So an expensive undertaking.
Okay, so I'd just like to finish off with a comment from Sarah Coupland and perhaps ask for your reaction to her comment. So Sarah says, NHS England is in the process of setting up so-called cancer vaccination launch pads, and these are linked to the genomic lab hubs and diagnostic centres. They are starting with colorectal carcinomas. It's good to see that the NHS is trying to keep up with this amazing science. What's your view on that, please?
Yes, so as of December last year, everyone's a cancer vaccinologist, and so you will know that the Department of Health and the Office of Life Science have entered into an agreement with both BioNTech and Moderna to deliver a whole program of cancer vaccine trials into the clinic in the UK preferentially, with a really ambitious delivery plan. So that field clearly is much bigger than these two companies, and multiple other players are entering the fray. So I think it's fantastic that this is becoming possible. And I think there are many sort of fringe benefits that will come from this, because if you deliver one set of trials promptly and swiftly, it will feed into how to do that. And that may make other trials deliverable more promptly and more swiftly also. So I think it's from my perspective, it's a thoroughly good idea on multiple levels, not least because I think that vaccines will play a major role in the sort of gamut of what we can deliver to our patients once this is all available. But of course, I would think that because I've been doing cancer vaccines for 20 years.
Okay, well, that just leaves me to thank you once again. Many of the people who asked questions have thanked you. In fact, Adrienne has said you've given a stimulating talk. I'd like to echo that. I found it a very stimulating lecture. with much food for thought, and it's clearly going to be a very interesting area of work which will grow and evolve as we move forward in the next few years. So I wish you the best of luck, because I think it's a really fascinating area. So
Thank you so much.
Thank you very much indeed.
I really appreciate it. Thank you. Goodbye.
Thank you. Bye, everybody.